Anesthesia Rounds, a series of discussions of clinical problems facing the anesthesiologist. Anesthesia Rounds is presented as a service to clinicians in the field of anesthesiology by Ayerst Laboratories. In this interview, Dr. M.T. Jenkins, McDermott Professor and Chairman, Department of Anesthesiology, the University of Texas Southwestern Medical School in Dallas, discusses the evaluation of the patient's fluid status and the management of fluid and electrolyte replacement. Among the questions that Dr. Jenkins will consider are when and how fluid and electrolyte status are evaluated, which intravenous fluids are used to bolster the circulation during elective surgery and in what sequence, the rationale of glucose, balanced salt, blood and plasma use, the basis for determining the quantity of fluid administered. Dr. Jenkins, when and how does the anesthesiologist evaluate his patient's fluid status?
Evaluation is made prior to surgery, of course. He usually sees the patient the day before surgery is scheduled.
What factors are measured?
The patient's chart may already indicate the levels of glucose and serum electrolytes, including most importantly sodium, chloride, and potassium. If there are questions about renal function, blood, urea, and nitrogen should also have been recorded. These measurements give us some information about the patient's fluid status, but only with respect to solute composition and concentration. The anesthesiologist must also be aware of two other parameters.
And what are those?
One is circulating volume, which is seldom indicated on a chart. The anesthesiologist usually depends upon physical signs to determine adequacy of volume. He must also know that distributional changes occur during anesthesia and surgery. Extracellular volume is distributed between the intravascular and interstitial spaces. Circulatory dynamics depend on the free exchange of fluid in a microcirculation between the two spaces. The dynamics are deranged in congestive heart failure and in shock. In these circumstances, the effective circulation is reduced in volume.
What are the physical signs of diminished fluid volume?
In the patient who has had an acute loss of volume, the signs primarily reflect cardiovascular changes and include increased pulse rate, tachycardia, and low blood pressure, particularly low systolic pressure. In the patient with a chronic deficit, however, the extracellular fluid volume, which is part-time intravascular, part-time extravascular, may be reduced while blood pressure and pulse rate remain at acceptable levels. Physical signs should be correlated with hemoglobin and hematocrit readings.
How does one detect moderate extracellular fluid deficit?
When I see a patient on a day before surgery, I usually clap a hand around his forearm while talking to him to observe whether the veins are full, suggesting an adequate circulating volume. At the same time, I'll look at his tongue. The tongue is an exposed muscle, an almost uncovered muscle, that reflects the extracellular fluid volume of other muscles of the body. If it is narrow, pointed, and longitudinally furrowed, then I suspect the patient has an extracellular fluid deficit.
What other easily determined clinical signs of diminished extracellular volume are there?
If the skin of the forearm, pinched between thumb and finger and held for a moment, stays in this pinched position when released, a loss of extracellular fluid usually is indicated. On the other hand, this sticking effect is also seen in a patient who has lost weight because of a debilitating illness or metastatic disease, because he will have lost subcutaneous tissue.
How then can loss of subcutaneous tissue be differentiated from loss of extracellular fluid?
There is no subcutaneous tissue on the forehead. Extracellular fluid loss is indicated by demonstrating the sticking effect there. If this sticky condition is present, I would assess the loss in an average adult patient about 5 feet 9 inches tall, for example, at 2 or 3 liters of extracellular fluid, or perhaps more. These estimates are gross, of course, but give indications for therapy.
What other clinical signs of diminished ECF volume occur?
The patient with a moderate deficit of extracellular fluid volume will be somewhat sleepy, apathetic, and anorexic. He will demonstrate a slow response to questioning. However, his lack of interest in himself and his surroundings usually will not reflect the gravity of his condition. With a severe deficit of extracellular fluid volume, the patient may be stuporous or even comatose. He will exhibit weakness and orthostatic hypotension. Superficial veins will be collapsed, and the extremities will be cold.
What do physical findings suggest with respect to electrolytes?
These fluid losses we were speaking of are due primarily to sodium deficiency, of course. There are physical signs of potassium loss also, but this deficit must be marked before the patient exhibits signs. Both sodium and potassium loss can occur in patients who have been on diuretics and who have been seriously ill. Muscle consistency will change. When you squeeze a muscle between the thumb and forefinger, it will have a putty-like feel, and the imprint of your fingers will persist for a while. The level of hypokalemia indicated by this is usually about 2 milliequivalents per liter. The physical signs I have mentioned are adequate to indicate the volume of balanced salt solution needed for replacement before anesthesia is begun. Without sufficient replacement, hypotension will occur during induction of anesthesia and will be severe.
What evaluation is made on the day of surgery?
I repeat this examination in the induction room. Occasionally, in a patient who has had an adequate circulating volume on a day before surgery, veins that stood up, I may not be able to find a vein, even using a tourniquet, on the day of surgery.
What explains this critical change?
Some cleansing enemas can cause the loss of a considerable quantity of extracellular fluid. If the patient has had nothing but mouth since, as is usually ordered, 10 p.m. or midnight, and which in actual fact may have been since 8 the night before, he will not have replaced his normal fluid losses. Some of this occurs as insensible loss through skin and respiration, and some loss, of course, occurs as urine.
You've referred to disturbances in composition, concentration, and particularly volume. What about those affecting distribution of extracellular fluid?
The anesthesiologist should be aware that a translocation of fluids occurs during the operative procedure in response to the necessary manipulations that may be called the trauma of surgery. Edema occurs in the wound edges and in retracted muscles. When the peritoneum is opened, additional ECF is lost into the abdominal viscera after they've been handled and packed off, and edema fluid often collects in the root of the mesentery. These are some of the places to which extracellular fluid is translocated, lost to the effective circulation in response to surgery. It is possible that an additional quantity is temporarily lost from the effective circulation in isotonic intracellular fluid shifts.
With what parenteral solution does one start infusion and why?
Our usual technique for patients undergoing elective surgery, in whom we have found no fluid imbalance or electrolyte change prior to surgery, is to start with an intravenous infusion of 500 milliliters of 5% dextrose in water, administering at least half of this before beginning anesthesia. We will discuss later the several reasons for doing this. I'll just point out now that as a patient's thirst in the morning indicates, he has lost some free water. This thirst occurs even when a belladonna drug is not part of the premedication. It reflects the normal osmolar concentration occurring in the patient who has been on a nothing-by-mouth regimen for quite a number of hours. Remember that even on a regular hospital diet, a patient will have accumulated about 1,200 milliosmoles, or about 60 grams of solute to be excreted in the urine each day. This first free water will help mobilize these solutes for urinary excretion.
Which parenteral fluids do you continue with?
For the average abdominal or thoracic procedure or orthopedic procedure on the hip, for example, we follow dextrose in water with 5% dextrose in lactated Ringer's solution. This is followed with subsequent infusions of lactated Ringer's solution, or we may administer glucose with the first 2 liters of this balanced salt solution. We usually administer these solutions at a rate of up to 15 milliliters per kilogram body weight for the first hour, and then at the rate of 10 milliliters per kilogram body weight per hour, unless there is some reason to speed up the infusion, such as unusual blood loss. After major blood loss, 300 to 700 milliliters, the significance of which is determined by its relationship to preoperative hemoglobin and hematocrit readings and the stage of the operation, we do replace blood, but we also give increased volumes of balanced salt solution. In major operative procedures, for example, a combined abdominal perineal resection, which involves considerable tissue manipulation, we give larger volumes. We administer up to a maximum of 30% of the patient's estimated preoperative extracellular fluid volume, and this comes to about 4 or 5 liters that may be administered in procedures lasting over 4 hours.
Why is glucose used and how much is used?
Glucose is administered for several reasons. First, it will prevent starvation ketoacidosis and the depletion of liver glycogen. Second, it supplies part of the daily caloric need of the patient. And third, in supplying part of these metabolic needs, it reduces the catabolism of protein and minimizes the associated negative nitrogen balance that is usually found in a postoperative period. A fourth reason is that glucose also provides free water, the water of oxidation, to replace insensible loss, to promote urine flow, and to assist in the renal excretion of ketone bodies, nitrogenous waste, electrolytes, drugs, and drug metabolites. And last, it reduces the loss of intracellular water and potassium, and extracellular electrolytes such as sodium. We recognize that anesthesia in the hypoglycemic patient may cause resistant hypotension. Hypoglycemia may be due to a poor preoperative nutritional state that may have been exaggerated by gastric suction or some other therapeutic procedure with similar effect.
What is the significance of liver glycogen depletion during surgery?
Marked depletion of glycogen stores and essential amino acids greatly increases susceptibility of the liver to potential hepatotoxins. Studies indicate that excessive mobilization of these nutrients during surgery can cause greater insult to the liver than hypoxia, hypotension, hypovolemia, or anesthetic overdose.
Can glucose meet the entire metabolic needs of the patient for the day of surgery?
No, the average adult patient would require about 600 grams of carbohydrate that day to meet his basic caloric requirements. He needs about 1,500 calories per day per square meter of body surface, and this is normally supplied by proteins and fats as well as carbohydrates. Our average patient with 1.7 square meters of body surface would need a caloric intake of 2,200 to 2,500 calories on the operative day. Intravenous glucose can't supply this many calories. The quantity needed would act as an osmotic diuretic and would be excreted in the urine. However, just 75 to 125 grams of glucose given during the operative procedure will appreciably diminish glycogen mobilization from the liver.
Why do you advocate lactated Ringer solution, Dr. Jenkins?
Primarily because it is a stable, balanced salt solution and is readily available in all hospitals. The essential need is that we provide fluid replacement with a balanced salt solution.
What is a balanced salt solution, Dr. Jenkins?
It is a salt solution that contains sodium, chloride, and among other cations, potassium and calcium. Lactate, an anion, metabolizes as bicarbonate and is a proton acceptor. To be balanced, a salt solution must have electrolyte milliequivalent values approximating those of interstitial fluid. Some solutions, similar to Hartmann's solution or lactated Ringers, use acetate or citrate in place of lactate, but these are also metabolized to bicarbonate.
What is the physiologic rationale for a balanced salt solution?
As I've said, a balanced salt solution approximates the milliequivalent values of electrolytes in plasma and interstitial fluid without protein. Such a solution will not change the osmotic relationship of interstitial fluid to intracellular fluid. It will bolster the circulating volume while maintaining the normal dynamics of the circulation. Therefore, even the administration of too much fluid will not change intracellular constituents. The overload will usually be excreted in the urine. The normal kidney has a great ability to compensate for an isotonic overload and can achieve a solute concentration of 1400 milliosmoles per liter. This is a major reason for using balanced salt solution as a support fluid for the patient undergoing anesthesia and surgery.
Why don't you use solutions containing bicarbonate?
Bicarbonate has a very short shelf life in mixed solutions. Therefore, balanced salt solutions are manufactured with a lactate or citrate or acetate, all of which, when metabolized by the liver, yield bicarbonate and energy.
Why give any fluid to a patient who comes to surgery without fluid imbalance? Why not replace blood loss with blood?
Blood loss should be replaced with blood, but giving balanced fluids compensates for extracellular fluid loss from the effective circulating volume. With tissue handling and tissue damage, extracellular fluid is lost from the dynamics of circulation into the traumatized area to appear as edema.
Please give us a fuller definition of dynamics of circulation.
I am referring to the basic physiological fact that under normal circumstances, extracellular fluid is a large mobile pool that is part-time intravascular and part-time extravascular. When it is in the extravascular space, it is spoken of as interstitial fluid. Circulating fluid and the electrolytes in this fluid flow from the arteriolar end of the capillaries into the interstitial space and subsequently into the cells, carrying cellular nutrients and oxygen. This extracellular fluid then re-enters the vascular system at the venous end of the microcirculation, carrying cellular waste products. This, then, I call the dynamics of circulation, the mechanism by which fluid normally circulates through the intravascular and interstitial extracellular fluid compartments.
Where is the extracellular fluid lost when it becomes unavailable to the effective circulation?
In a term somewhat less than exact, we refer to the third space, into which fluid is translocated from the circulation, in which it is sequestered as edematous fluid. Of course, there is no real third space, unless one defines it as an interstitial area that does not communicate with the circulation or intracellular spaces containing translocated isotonic fluid. Translocation of extracellular fluid is seen in burns and contusions, around fractures, and in peritonitis.
How much extracellular fluid can be lost with peritonitis?
Considering that the peritoneal surface of an adult is about 3/4 to 1 1/2 square meters, if there were only 1 millimeter of edema under this surface, it would represent 750 to 1,500 milliliters of fluid lost to the circulation. With peritonitis, however, the root of the mesentery and part of the peritoneal surface will usually show several millimeters of edema, 4 or 5 or perhaps 6 millimeters. The intestinal wall will have thickened, and with the arrest of peristalsis, there is an increased secretion of fluids into the lumen of the bowel. When we consider all these factors, we recognize that there may be 4 to 5 liters of extracellular fluid lost from the circulation with peritonitis.
Why not use only large volumes of glucose and water to bolster the circulation?
When we use water or glucose in water to replace lost fluid, we change the relationship of interstitial fluid to intracellular fluid. The result can be water intoxication. In fact, by giving large volumes of glucose in water, we can actually produce cerebral edema. This would be indicated by a prolonged awakening time from anesthesia, and because of dilutional hyponatremia, even convulsions may occur.
Why isn't normal saline used for fluid replacement?
First, let me challenge the term. Normal saline is not really a normal solution. It's 9/10 normal. It's also frequently called physiological saline, but it is not physiological either, since it contains 155 milliequivalents per liter each of sodium and chloride. It has another defect in that it does not contain bicarbonate, or an anion that will metabolize to bicarbonate. It is isotonic saline, and the infusion of large volumes can produce dilutional acidosis.
What about the use of plasma?
Plasma has advantages if the patient is hypoproteinemic at the time he comes to the operating room. However, if he has lost a good deal of blood, or if he is in a shock state, a hypovolemic, hypotensive state, there are hazards in its use, primarily those related to plasma's potassium and sodium content. Plasma prepared from old blood may have a potassium content up to 25 milliequivalents per liter. If we add this to the increased potassium released from the liver in cases of shock, it may produce cardiac arrest.
Why would you advocate using balanced salt solution rather than albumin or a plasma expander?
Albumin is used quite frequently as a method of bolstering intravascular volume, but I feel it shouldn't be unless the patient has a protein deficiency. At first, albumin will expand intravascular volume, primarily by increasing oncotic pressure at the expense of the interstitial fluid volume. Its use and that of plasma expanders is in conflict with our conception of a circulating fluid being one that is part-time intravascular and part-time interstitial. There are specific indications for plasma and albumin, but they are not related to normal fluid replacement.
Is the circulating volume related to body size or shape?
In the average non-obese adult male, the total interstitial fluid is about 15% of body weight, and total plasma represents about 5% of body weight. Because adipose tissue contains even less water than bone, the fat person has a smaller extracellular fluid volume per pound body weight than the normally lean person. The infant or child has a much greater relative volume of extracellular fluid than does the adult. Indeed, the total extracellular fluid for an infant may be 35 to 40% of body weight. The difficulties associated with diarrhea or vomiting may be more critical in the infant than in the adult because of the proportionally greater losses of extracellular fluid that may occur.
Now that we have discussed the values of balanced salt solution, on what basis do you determine the quantity to administer?
During the years since 1950 that we have been using balanced salt solutions during anesthesia and surgery, we have come to a procedural usage. I hesitate to call it a routine. We administer about 15 milliliters per kilogram of body weight for the first hour of an operation that involves the abdomen or hip. After the first hour, we may change to a rate of infusion not exceeding 10 milliliters per kilogram per hour unless the patient sustains considerable blood loss. In that case, we replace blood loss with blood and give balanced fluids at an increased rate. The determining factor in long procedures is the amount of urine output. We usually endeavor, by giving sufficient fluid, to achieve an output of at least 50 milliliters of urine per hour.
What is the usual rate of infusion for intrathoracic or intracranial procedures?
The volumes we expect to use in abdominal cases is determined by the amount of anticipated tissue handling and is based on the quantity needing in our experience to achieve an adequate urine output. For chest procedures in which there is usually less tissue manipulation, we infuse less, usually 5 to 10 milliliters per kilogram the first hour, unless the procedure is one which involves considerable blood loss or, atypically, much tissue handling, such as a lung decortication procedure. For intracranial procedures, we generally drip balanced salt solutions at a rate just sufficient to keep a vein open, replacing blood as blood is lost, unless there was a preoperative fluid imbalance. If the neurosurgical patient comes to the operating room exhibiting major deficits of extracellular fluid, we will begin replacement. This may occur in those patients who have received antihypertensive agents or diuretic drugs that may cause low serum sodium, potassium, and volume. We recognize that giving any glucose in water may result in further swelling of the cerebral cells.
What quantities of salt solutions are given to infants or children?
Your question presupposes that we use balanced salt solutions in infants and children just as we use them in adults, a practice that may be somewhat at variance with established custom throughout the country, and you are correct. We feel that the infant also translocates fluids out of the effective circulation during surgery. The concern with respect to giving salt solutions to infants has been their ability to concentrate urine and excrete salts administered in excess of immediate need. It is true that the newborn secretes a relatively large volume of dilute hypotonic urine, consistent with his relatively large extracellular volume. We are also aware, however, that an infant past his neonatal days has the ability to concentrate urine, in some circumstances to a specific gravity as high as 1.025. Consequently, we feel that the use of a balanced salt solution to bolster his circulation will impose no unusual workload on the kidney and his proper fluid management.
Do you use central venous pressure monitoring as a guide to fluid replacement?
No, not always. We do use central venous pressure monitoring to learn whether a patient's heart has the ability to maintain its integrity when, for example, he has been brought to the operating room after trauma or hemorrhagic shock. His central venous pressure may rise as an indication of a failing heart, and yet there may be indications for the administration of additional fluids. In this circumstance, we digitalize a patient or would add to his digitalis if he was previously digitalized. With a low central venous pressure reading, we increase the volume of fluid administered unless there is sufficient urinary output, that is, about 50 milliliters per hour.
When is blood also used? Is the guide to the replacement of blood loss the hematocrit, blood loss measurements, or physical signs?
I'm glad you asked that question because you presuppose that we do give blood on occasions. I think we're sometimes the target of jokes that depict us as the saltwater capital of the world, implying that we don't give much blood. This is not a true assessment. We give blood as blood is needed, and will administer it along with salt solutions. We do not give salt water to replace blood loss. We consider giving blood to the patient who had relatively normal preoperative hemoglobin and hematocrit levels when he has lost about 600 to 700 milliliters, but prefer to transfuse in the recovery room when he is nearly awake so that we can more easily recognize a blood transfusion reaction. If, however, he has lost this much blood early in the operative procedure, we go ahead with blood administration at this time, but also continue with balanced salt solutions. I should say here that when circulating volume is maintained with balanced salts, there will be fewer indications on the basis of blood pressure and pulse changes for intraoperative blood administration. The criterion must be intraoperative estimation of blood loss.
What is your attitude to the concept of renal intolerance to or retention of salt during anesthesia?
Our general feeling is that the patient who does not excrete salt and water as urine during or following anesthesia and surgery has a deficit of extracellular fluid. It is so well documented that postoperative and post-traumatic patients demonstrate marked water and salt retention that many clinics have assiduously restricted the use of salt solutions during surgery. However, it now appears, and we believe, that the postoperative retention of sodium is related to the diminution of circulating extracellular fluid volume. Consequently, we feel there will be no renal retention with adequate replacement. Rather than renal intolerance to water and sodium, retention represents the kidney's effort to prevent further diminution of extracellular volume.
Do you catheterize all patients to determine whether the volume infused is sufficient to compensate for the extracellular fluid which is lost to the effective circulation?
No, not all patients during elective surgery. The discussion has implied that we know on the basis of clinical signs when we have caught up with fluid loss incident to surgical trauma. However, if the operative procedure is major and is expected to last for several hours, then the patient will be catheterized with all sterile precautions being taken, including a sterilized closed drainage system. In emergency surgery, particularly following trauma and blood loss, the patient usually arrives in the operating room with a catheter in place. It is essential that the patient whose exact status is not known have a catheter in place so that we can monitor urine output.
Shouldn't salt be withheld from the cardiac patient?
The same basic thesis holds for the cardiac patients having major surgery and a patient who has a normal cardiovascular system. There may be a translocation of fluid from the effective circulation if the operative procedure involves extensive tissue manipulation and if blood loss is extensive. Therefore, we administer balanced salt solutions to the cardiac patient in a similar manner. However, we must be aware that the previously digitalized patient may not be sufficiently digitalized for the additional stress of anesthesia. Our attitude is that we will add digitalis should signs of failure appear, but will continue with fluid administration. We do monitor central venous pressure in these patients, primarily to assess the status of the pump.
What about the cardiac patient with edema?
The digitalized patient need not be free of peripheral edema prior to anesthesia. In fact, if he is, and if this is due to diuretics, he may be hypovolemic and may respond to anesthesia by becoming alarmingly hypotensive. In this circumstance, we certainly have an indication for giving a balanced salt solution, as well as for lightening the plane of anesthesia. In general, the cardiac patient in compensated or uncompensated failure should be carefully monitored. Increased ventilatory resistance, increased central venous pressure, hypotension, and tachycardia indicate failure or inadequate digitalization.
What are your considerations in giving fluid to the patient who's been brought into the hospital in a state of shock and who may have renal shutdown?
Once volume has been restored, as indicated by an acceptable blood pressure and pulse rate, the cause of a persistent oliguria can be determined by the rapid infusion of 500 to 700 milliliters of balanced salt solution, lactated Ringer's solution, while the central venous pressure is being monitored. If the central venous pressure rises appreciably without an associated increase in output, renal shutdown rather than renal defense of a diminished extracellular volume is indicated. The possibility of renal failure is greater if fluids are not given to the shock patient than if they are. With overload in the presence of anoxic anuric renal failure, excess fluid can be removed by dialysis. The patient who sustained shock following major trauma should be followed very closely in the postoperative period, particularly with respect to serum sodium and potassium levels, even though urine output is satisfactory, because he may have an incomplete renal failure, the so-called high output renal failure, in which he puts out a sufficient volume of urine but insufficient potassium and becomes hyperkalemic.
Do the fluid requirements change according to the anesthetic agent or technique employed in surgery?
No, we think that anesthetic agents and techniques are not of importance in the translocation of fluids, assuming that the patient is not very deeply anesthetized. Studies indicate that extracellular fluid shifts are due to what we must call trauma, extrinsic or operative, and not to anesthetics.
Thank you very much, Dr. Jenkins, for a most informative discussion. Anesthesia Rounds is presented as a service to clinicians in the field of anesthesiology by Ayerst Laboratories.
Anesthesia Rounds, a series of discussions of clinical problems facing the anesthesiologist. Anesthesia Rounds is presented as a service to clinicians in the field of anesthesiology by Airst Laboratories. In this interview, Dr. Joseph S. Redding, anesthesiologist-in-chief, Baltimore City Hospitals, and professor and associate professor, respectively, at the University of Maryland and Johns Hopkins University, discusses the many physiologic factors encompassed by the term drowning. He also discusses the several procedures that may be necessary for reviving those who have been submerged to the point of asphyxia. Among the questions that Dr. Redding will consider are similarities and differences between saltwater and freshwater drowning, the specific sequence of physiologic derangements occurring in each type of drowning, initial and continuing treatment of the drowning victim. What occurs during the early stages of drowning, and what is the sequence of events?
Although more than 6,000 people die each year in this country as a result of drowning, no details about the sequence of events have been reported for obvious reasons.
What then is the source of our information on this subject?
Our knowledge of what happens in man has been derived from observations of the sequence of events during experimental drowning, taking into account the physiologic differences between species. Experimental evidence indicates that submersion is followed by a period of breath holding and struggling that is of markedly variable duration. This is followed by the swallowing of large volumes of water and then by vomiting. We know that in obtunded humans, fluid in the pharynx and larynx produces severe and protracted laryngospasm. It's reasonable to assume that this occurs during the drowning process.
Does laryngospasm persist until death occurs?
With progressively increasing asphyxia, the victim becomes flaccid and the larynx relaxes. It has been estimated that fewer than 10% of drowning victims die of acute asphyxia before laryngeal relaxation occurs.
What follows relaxation of the larynx?
Once asphyxia becomes so profound that the victim's glottic muscles relax, the lungs become flooded with salt or fresh water and with the gastric contents if he vomited. We have no reason to assume that this sequence of events differs appreciably in freshwater and saltwater drowning.
Then flooding of the lungs usually occurs during drowning, whatever the circumstances.
Yes, so-called dry drowning or asphyxial death before water floods the lungs is an unusual event. The lungs flood when asphyxia becomes so profound that the laryngeal reflexes are obtunded and laryngospasm abates.
How long does this take? Does it depend on whether the victim is drowning in salt or fresh water?
The time interval after submersion necessary to create these conditions must vary tremendously from one individual to another. The level of consciousness of the individual at the time he submerged, his ability as a swimmer, his physical endurance must all play a role. We know from research that an animal is asphyxiated much more rapidly if his airway is obstructed at the end of exhalation than if it is obstructed at the end of inspiration. We have no reason to assume that the type of water in which the victim is submerged affects the time interval from submersion to relaxation of the glottis. I think that most of our ideas about the time intervals involved in resuscitation are little better than educated guesses and consequently provide very poor guidelines for determining what should or should not be done in attempting to resuscitate the individual.
What physiologic changes are associated with flooding of the lungs? And in what way does drowning in salt water differ from drowning in fresh water?
Once the victim's glottic muscles relax, subsequent events are determined by the composition of the fluid that floods the lungs. In freshwater drowning, large volumes of water pass through the lungs and into the circulation with extreme rapidity. There is evidence that the circulating blood volume may be doubled within 2 minutes. This marked hemodilution results in massive hemolysis, blood concentrations of sodium, chloride, calcium, and plasma proteins are markedly reduced. The combination of hypoxia and the relative hyponatremia of hemodilution sometimes leads to sudden ventricular fibrillation and death. Even if fibrillation does not occur, or if it's corrected, the massive hypervolemia results in heart failure and fulminating pulmonary edema.
What physiologic changes occur with saltwater drowning?
Seawater contains 3.5% mixed salts and consequently is markedly hypertonic to blood. These salts diffuse into the blood when seawater is aspirated and cause a rapid elevation of the plasma sodium. The osmotic effect of the seawater in the lung causes the loss of large amounts of fluid from the circulation into the lungs. As the alveolar membrane is damaged, plasma protein is also lost into the lung fluid. The end result is a fulminating pulmonary edema, hypotension, bradycardia, and death.
Should an attempt be made to empty the lungs?
No time should be wasted in efforts to drain fluid from the airway or lungs of a drowning victim. As a previous discussion indicated, when the victim drowns in fresh water, the fluid will pass rapidly into the circulation. Therefore, the lungs are relatively dry. When the victim drowns in seawater, the osmotic effect results in a reaccumulation of fluid in the lungs more rapidly than it can be removed. In a study of this subject, both postural drainage and external pressure failed to drain significant amounts of water from the lungs of cadavers, even when they contained as much as 2 liters of 1% saline. Inflation of the lungs did not force water out of the airway, nor did it cause water to drain from the stomach. On the other hand, inflation of the stomach did cause regurgitation of water. For these reasons, any time that is spent in attempts to drain the lungs of drowning victims is wasted. The first measure should be the clearing of foreign material from the pharynx and inflation of the lungs at the earliest possible moment by direct mouth-to-mouth breathing.
Is the cause of death the same in both saltwater and freshwater drowning?
Certainly asphyxial changes are a major component in either type of drowning. However, when large amounts of fluid are aspirated in the process, the circulatory changes just described are superimposed on asphyxial death. Aspiration of large amounts of fresh water may lead to marked hypervolemia, hemolysis, pulmonary edema, and under appropriate conditions, sudden ventricular fibrillation, which may be the mechanism of death. Aspiration of large amounts of seawater in combination with asphyxia leads to severe hypovolemia, hypotension, and cardiac standstill.
How do you explain stories of survival after 10 or 15 minutes of submersion?
For a number of years, we have tried to collect reliable case histories of the events associated with death by drowning. In most cases, the only thing we can really be sure of is that the victim was wet when he was removed from the water. I do not find it incredible that victims may survive after 10 or 15 minutes of presumed or even real submersion. We know that the time intervals involved in the sequence of physiologic events we've already discussed are quite variable. Experimentally, it may take as much as 10 minutes for an animal to asphyxiate to the point of circulatory arrest when his airway is obstructed after exhalation. The time can be much longer when obstruction occurs after inspiration. This could account for major differences in the time needed to cause irreversible physiologic changes.
Does the temperature of the water have any effect on the time elements?
We don't have any reliable evidence on which to base an opinion regarding the effect of water temperature on the drowning process. One might speculate that the cold water would lead to shivering associated with increased oxygen consumption and carbon dioxide production. This would tend to make asphyxiation occur more rapidly in cold water. But reduced body temperature would theoretically make tissue death occur more slowly after circulatory arrest.
Is there any evidence to support these assumptions?
There is. For example, a case report on a 5-year-old boy who was submerged for an estimated 22 minutes. The river in which he was submerged was partially frozen, the temperature that day being about minus 10 degrees centigrade. The fact that his heart did not resume normal contractions for approximately 2 hours makes it remarkable that he recovered with only minor neurological and mental sequelae. It's been suggested that cooling of the child's body as he hung onto the ice and hypothermia during treatment may have played an important part in the successful outcome. However, we do not have substantial evidence on which to base an opinion regarding the effect of temperature.
What post-mortem changes are found in drowning victims?
Post-mortem examination of drowning victims often shows a striking light pink coloration of the skin, suggestive of carbon monoxide poisoning. Goose flesh is often seen. Frothy pulmonary edema fluid may fill the lungs and airway and exude from the nose and mouth.
What pulmonary changes are seen?
When the chest is opened, the lungs appear hyperexpanded, and petechial subpleural hemorrhages are commonly seen. Microscopic examination often reveals seaweed, sand, mud, or algae. There's diffuse capillary congestion of the alveolar walls.
What other findings are made?
The upper gastrointestinal tract may be filled with ingested fluid and foreign material. Biochemical and morphologic alterations in the blood may be discovered. These changes are only suggestive of the drastic physiologic alterations which precede death. It must be remembered that the fluid and electrolyte abnormalities which we discussed earlier are very transient. Fluid and electrolyte redistribution occur very rapidly after drowning, so that blood specimens taken as soon as 30 to 60 minutes afterward show little evidence of the marked abnormalities that existed earlier.
Assuming the arrival in the emergency room of a dead patient, one who is not responding to artificial respiration and cardiac massage, what is the appropriate emergency treatment? Does it vary according to whether the victim has been submerged in salt or fresh water?
The initial resuscitation measures are the same, whether the victim drowned in fresh water or salt water. As soon as equipment is available, mouth-to-mouth ventilation of the lungs should be replaced by intermittent positive pressure breathing with 100% oxygen. A high diffusion gradient is needed if adequate arterial oxygenation is to be achieved. To maintain circulation, closed chest cardiac massage should be continued, and an adequate dose of a peripheral vasoconstrictor should be given without delay.
What agents and routes do you use?
We use single doses of epinephrine, 1 milligram, phenylephrine, 10 milligrams, or methoxamine, 20 milligrams, in adults and large children. Whichever drug is chosen, it should be given by whatever route is most readily available, intracardiac, intravenous, or transtracheally. It may be diluted with water and injected down the trachea. An electrocardiographic tracing must then be obtained to determine whether ventricular fibrillation is present. If fibrillation is present, external electrical countershock should be used to correct it. Closed chest cardiac massage should be continued and vasoconstrictors repeated at intervals until a spontaneous pulse is restored. Artificial ventilation with oxygen must be continued until blood gases indicate that respiration is close to normal.
What is your approach in emergency treatment to the metabolic acidosis associated with circulatory arrest?
Sodium bicarbonate in doses of 44 milliequivalents may be given every 5 to 10 minutes until the heart is restarted. Precise correction of metabolic acidosis depends on serial determinations of arterial blood gases and pH made after spontaneous circulation has been restored.
What other immediate steps should be taken?
During the resuscitation period, intermittent positive pressure breathing with 100% oxygen must not be interrupted. It may be facilitated by endotracheal intubation or tracheotomy. Blood and urine specimens should be promptly drawn and examined for evidence of hemolysis and electrolyte disturbance. Free hemoglobin levels in the neighborhood of 500 milligrams per 100 milliliters have been reported following aspiration of fresh water. If severe hemolysis has occurred, then partial exchange transfusion must be considered. If massive pulmonary edema is present, phlebotomy and treatment with vasodilator drugs should be considered once circulation is restored. If the victim has aspirated large amounts of seawater, any deficiency in the circulating blood volume must be compensated for by the infusion of plasma. Monitoring of central venous pressure is a valuable guide to fluid therapy.
Assuming emergency therapy has been successful, what continuing treatment is indicated?
After resuscitation, the most severe problem in the management of any patient who has aspirated large volumes of fresh or seawater is usually arterial hypoxemia and acidosis, although cardiovascular changes may still be life-threatening. Destruction or alteration of the alveolar membrane and lung surfactant material causes major regional ventilation and diffusion defects and significant shunting of the pulmonary blood flow. Arterial blood should be drawn for determination of pH, PCO2, and PO2 as soon as possible. Findings determine the need of bicarbonate administration, and they also indicate the need for continued ventilatory support with high oxygen concentrations. Ventilation may be facilitated by the use of bronchodilators. Pneumonitis should be treated with steroids and antibiotics.
For how long is assisted ventilation required?
Pulmonary shunting usually subsides within 48 to 72 hours. After this period, spontaneous breathing is permissible, but supplementary oxygen is often still necessary. The inspired oxygen concentration should be reduced step by step to normal as soon as a normal arterial PO2 value can be maintained with the lower concentration. Serial blood gas determinations provide the basis for all these decisions on ventilatory care.
What other aspects of ventilatory care following resuscitation should be stressed?
When a patient is resuscitated following circulatory arrest, his reflexes are usually obtunded. Both circulation and respiration require constant support. Passive hyperventilation with high oxygen concentrations should be continued into the post-resuscitation period, and it is usually advisable to remove the endotracheal tube and do a tracheotomy, particularly if assisted ventilation must be continued for more than 1 day. Close attention must be paid to the humidification of the inhaled gas, to prevention of infection when suctioning secretions, and to artificial coughing and sighing. Frequent changes in the patient's position are necessary. It may be desirable to cool the patient to about 32 degrees centigrade body temperature to reduce oxygen consumption and carbon dioxide production. Shivering must be prevented, and this may be accomplished by the use of chlorpromazine hydrochloride, morphine, or muscle relaxants.
Water intoxication frequently leads to cerebral edema. How is this condition managed in the revived drowning victim?
Cerebral edema often follows asphyxia and circulatory arrest, as well as the hypervolemia associated with freshwater drowning, and the resulting increase in intracranial pressure leads to the death of additional cerebral substance. The condition will have been alleviated to some degree by the use of passive hyperventilation, which will induce respiratory alkalosis, and of hypothermia, and by the correction of metabolic acidosis. Osmotic diuresis may be a desirable additional measure if physical signs, papilledema for example, persist. Hypertonic mannitol or dextrose are the agents most commonly used for this purpose.
What data explain the relatively recent adoption of mouth-to-mouth techniques of artificial respiration after decades of experience with prone pressure techniques?
Early studies of the effectiveness of the conventional back pressure arm lift and chest pressure arm lift methods of artificial respiration were performed on curerized healthy adults whose tracheas were intubated. The volunteers were tall, lean men. Use of intubated subjects with such a body configuration led to the false impression that manual artificial respiration is far more effective than it really is under emergency conditions.
Is there reliable evidence that prone pressure methods are without value?
In subsequent studies carried out in the late 1950s, the tidal volumes produced by back pressure arm lift and chest pressure arm lift methods in anesthetized, curerized adults were compared with and without an artificial oropharyngeal airway and with and without an endotracheal tube in place. With the back pressure arm lift method and without artificial airway, the tidal volume was either 0 or less than dead space air in 12 of 15 subjects. This inadequacy was mainly due to pharyngeal obstruction by the relaxed tongue. Insertion of an artificial oropharyngeal airway only slightly improved the tidal exchange. Even with an endotracheal tube in place, tidal volumes were low in short and obese subjects with reduced lung-thorax compliance. In these subjects, the tidal volume was often less than dead space air. Properly performed mouth-to-mouth resuscitation takes into account the crucial problem of soft tissue obstruction of the upper airway in the unconscious victim.
In what way is this problem overcome in mouth-to-mouth resuscitation?
Maximal backward tilt of the head and forward displacement of the mandible are integral parts of the mouth-to-mouth method. With the head and jaw in the proper position, tidal volumes in excess of 1 liter can be delivered even to the short, obese person with increased airway resistance. The method is reliable in the hands of trained laymen using no equipment whatever. In one study, 35 rescuers, including Boy Scouts, housewives, and rescue personnel, were called back to Baltimore City hospitals 1 year after their initial training. They were unaware that they were to be tested. They were called one at a time into a room where a curerized subject was lying on the floor and were asked to breathe for him immediately. 83% of these rescuers were successful in ventilating the victim within 60 seconds.
If the prone pressure techniques are so poor, in effect useless, why did their use persist and how were lives saved?
In 1846, Sir Benjamin Brodie wrote, "Of those who recover from a state approaching to dissolution, a greater number will owe their recovery to unassisted nature than to the most judicious treatment. But let us not on this account undervalue the knowledge which physiological investigations throw on this interesting subject." Sir Benjamin explained how lives may have been saved. It is most unusual during clinical resuscitation for the rescuer to have precise knowledge of the victim's physiologic condition. Resuscitation is sometimes performed on patients who would survive spontaneously. As a result, ineffective resuscitation techniques have often been credited with saving the lives of victims who survive spontaneously. As a result, ineffective resuscitation techniques have often been credited with saving the lives of victims who survive spontaneously, or even in spite of the methods of resuscitation employed.
Are there firm data to prove that mouth-to-mouth resuscitation will save a life that would otherwise be lost?
It's certainly indicated that the mouth-to-mouth method is more effective and reliable in ventilating the lungs of an asphyxiated victim than the prone pressure methods. Reoxygenation of a moderately asphyxiated subject can be accomplished with approximately 5 deep mouth-to-mouth inflations. The victim's oxygen saturation and end expiratory carbon dioxide tension can be maintained at normal levels for an almost unlimited period of time with tidal volumes of 1 liter or more at a rate of 10 inflations per minute. Extreme hyperventilation by the rescuer is unnecessary, even undesirable, because the rescuer usually becomes dizzy if his own end expiratory carbon dioxide concentration is reduced below 3%. If the victim's problem is asphyxiation, and if ventilation of his lungs will affect resuscitation, then the data firmly indicate that mouth-to-mouth artificial respiration is much more likely to save his life than are the pressure methods.
Should every physician carry a resuscitube or modification thereof, or is the chin-forward position sufficient to prevent oropharyngeal obstruction?
In a study conducted at Baltimore City Hospital some years ago, airway patency was studied in 50 anesthetized, spontaneously breathing patients. With comparable head-jaw positions, the incidence and degree of obstruction was the same in the supine as in the prone position. The common belief that the tongue falls forward when one is in the prone position is erroneous. The decisive factor in pharyngeal soft tissue obstruction is the degree of stretch between the larynx and the chin. With the neck flexed, the tongue is pressed against the posterior pharyngeal wall, and the epiglottis may obstruct the larynx. Insertion of an artificial oropharyngeal airway in the presence of neck flexion does not relieve obstruction. With the head tilted back, 5% of the patients were completely obstructed, and 45% were partially obstructed. When forward displacement of the mandible was added to maximal backward tilting of the head, only 1 patient was completely obstructed. There was no complete obstruction with the head tilted back and an oropharyngeal airway inserted.
What then are the indications for using a portable artificial airway?
The chief value of an oropharyngeal airway in maintaining airway patency is that it relieves the rescuer of the necessity for holding the jaw displaced. The resuscitube is only a modification of an ordinary oropharyngeal airway. Therefore, the indications for its use are the same as for any oropharyngeal airway. An artificial airway provides the additional advantage of making it possible to ventilate the victim without direct mouth-to-mouth contact. During 10 years of activity in the field of resuscitation, I have not yet encountered a victim with whom I particularly wished to make direct mouth-to-mouth contact. All too often, the victim has copious secretions, has recently vomited, or has poor oral hygiene. Although the resuscitube is useful in this way, it has the disadvantage that it is often somewhere else when needed. Certainly, resuscitation of an asphyxiated victim should never be delayed to obtain any item of equipment.
Vomiting may be provoked by an artificial airway. Does this factor affect its range of usefulness?
Stimulation of the pharyngeal wall in an unconscious victim who is not deeply obtunded certainly can lead to gagging, vomiting, and aspiration. No type of artificial oropharyngeal airway should be inserted in the lightly unconscious victim. Because of this danger, the resuscitube has been shortened, making stimulation of the pharynx less likely. Possibly this also makes it less effective in relieving airway obstruction.
Are there advantages in using the nasopharyngeal airway in resuscitation?
The natural nasopharyngeal airway is often obstructed in victims who need resuscitation. In one of our experiments on curorized volunteers, we found that mouth-to-nose breathing met partial airway obstruction in 50% of the subjects, even with maximal backward tilt of the head and with the mandible displaced forward. In all these subjects, mouth-to-mouth breathing produced larger tidal volumes than mouth-to-nose breathing by the same lay rescuers. We found partial or complete obstruction of one or both nasal passages in 25 of 100 conscious normal adults. Insertion of an artificial nasopharyngeal airway can be time-consuming and difficult for the inexperienced rescuer, and it often leads to epistaxis.
What about the use of endotracheal intubation?
Endotracheal intubation should not be the first measure in resuscitation. Exposure of the glottis and intubation of the trachea frequently cause cardiac arrhythmias. In the presence of asphyxia, these procedures may cause reflex cardiac arrest, granting the heart is still beating. Attempts to ventilate the lungs and improve oxygenation should always precede tracheal intubation.
When is the time necessary for endotracheal intubation justified?
Only when all other measures fail to achieve adequate ventilation should tracheal intubation be carried out before preliminary reoxygenation. Otherwise, the trachea should be intubated after the lungs have been ventilated and the patient's color improves. The major reasons for intubating the trachea during resuscitation are to prevent the aspiration of gastric contents and to prevent distension of the stomach during intermittent positive pressure breathing. The physician who is not experienced and skillful at tracheal intubation is much more likely to achieve a successful resuscitation if he does not attempt intubation. The inexperienced rescuer often spends too much time attempting tracheal intubation, time that could have been devoted to ventilating the lungs by simpler means. Unskilled attempts at intubation may result in intubation of the esophagus or a bronchus or the precipitation of vomiting and aspiration.
What rates and volumes of air should be used by the person providing ventilation?
A rate of about 10 breaths per minute with tidal volumes in the neighborhood of 1 liter have been shown to be about optimal for resuscitation of the average adult. Rapid, shallow breathing may do little more than ventilate the dead space. If the rescuer does not attempt to breathe for the victim more than once every 5 seconds, he will avoid becoming dizzy from hypocapnia. Patients vary in size, and consequently the tidal volume must vary with the patient. The airway pressure necessary to inflate the lungs of an apneic patient with a given volume of air varies tremendously from patient to patient, and even in the same patient under different conditions. If artificial respiration is to be effective, the rescuer must be able to adjust the pressure and volume of each inflation to the resistance encountered. Neither the chest pressure methods nor mechanically cycled fixed pressure resuscitators provide such flexibility.
How is pulmonary resuscitation performed when a chest injury is present? Pneumothorax or flail chest, for example.
The basic principles of pulmonary resuscitation that we've just discussed apply to the patient with either pneumothorax or flail chest. There are, however, some special considerations in treating these patients. The patient with flail chest may be conscious and attempting to breathe, but moving inadequate volumes of air. Initially, his inspiratory effort should be assisted by mouth-to-mouth breathing, and the rate and volume of the inflations should be gradually increased. As the rate and volume are increased, respiratory alkalosis is produced in the victim. Controlled hyperventilation can then be continued mechanically for days or even for weeks, obviating the need for complicated and ineffective methods of applying fixation or countertraction to the ribs. Controlled hyperventilation of the patient with a flail chest has an additional advantage. Pain from the rib fractures is relieved. Many patients with traumatic flail chest also have concurrent intra-abdominal injuries. The patient in pain from a flail chest has abdominal rigidity due to involuntary guarding. Therefore, abdominal palpation often does not reveal these injuries. Once the pain is relieved by controlled hyperventilation, the abdomen relaxes and can be palpated.
What special considerations apply when treating the patient with a pneumothorax?
The asphyxiating patient with a closed pneumothorax must also receive intermittent positive pressure breathing if he is to survive. However, the fact that he has a pneumothorax must be recognized and the condition treated immediately. If this is not done, each breath which is delivered to the patient causes his pneumothorax to increase, and there is an associated progressive increase in the amount of atelectasis and shunting of pulmonary blood flow. The mediastinum may be shifted. Hypotension becomes more and more severe. A large bore needle or a chest tube should be promptly placed in the victim's pleural space to permit escape of air. Controlled hyperventilation is continued.
How do you gauge the degree of success you are having during the process of resuscitation?
The patient's state of consciousness is the best indication of the success of the resuscitative effort. The earlier reflex activity returns, the more likely is the patient to recover fully. Steadily progressive return of consciousness is encouraging, in contrast to the development of plateaus, during which the patient shows no progress. Serial electroencephalograms may be of assistance in following the course of returning cerebral function.
If resuscitation efforts fail and the victim meets all the criteria of death, are organs suitable for transplant?
At this stage of our knowledge, insufficient data are available to judge whether a drowning victim's organs are suitable for transplant. The recent flurry of interest in cardiac transplantation poses questions which we are unable to answer. So far, little has been done in the way of studying resuscitation following prolonged periods of circulatory arrest with respect to providing a major source of donor material. In one recent study, donor hearts were removed from dogs used in resuscitation studies and stored for 4 hours before orthotopic transplantation. 8 of 10 transplants survived 48 hours. Other animals with cardiac arrest were allowed to remain in the cadaveric state for 30 minutes, after which their hearts were cooled and stored for 3 hours. 90% of these hearts were resuscitated in vitro. As transplantation becomes more common, there will be increasing need for data relating cardiopulmonary resuscitation to the provision of useful donor material. Methods of recognizing which organs are useful for donor purposes are needed, and so are methods of preserving organs for transplantation.
Thank you for an interesting discussion, Dr. Redding. Anesthesia Rounds is presented as a service to clinicians in the field of anesthesiology by Airst Laboratories. Anesthesia Rounds. Anesthesia Rounds is presented to clinicians in the field of anesthesiology by Airst Laboratories. In this discussion, Dr. Martin I. Gold, professor of anesthesiology, University of Maryland School of Medicine, discusses the anesthetic management of the asthmatic patient during surgery or a severe protracted attack. Dr. Gold, please define asthma and its pathophysiology.
Though asthmatic attacks may appear clinically identical, the conditions giving rise to the attacks vary widely from a pathophysiologic point of view. It is unfortunate that the term asthma embraces such a wide variety of meanings both here and abroad. In some countries, the physical signs of bronchial obstruction denote asthma, and the word is used synonymously with bronchospasm or bronchoconstriction.
Does the term have some common meaning wherever used?
The common denominator of asthma anywhere seems to be the presence of a wheeze. And a dictionary definition is that a wheeze is a musical or sonorous rail heard over all lung fields, appearing primarily during long expiration.
How do you define a rail?
I should define the word in a broad sense and designate as rails all noises produced during respiration by the passage of air through liquids in the air passages. This means that asthma in the broadest sense may be described as a feature of any disease in which wheezes or rails are audible, including bronchiolitis, emphysema, and even acute pulmonary edema, which is still unfortunately described by some as cardiac asthma.
How would you define asthma as a clinical entity?
The term asthma should probably be reserved for a condition involving intermittent episodes of bronchospasm associated with wheezing and symptom-free periods in a patient who has a personal or family history of allergy. In true acute asthma, there is no infection. Therefore, a suspected asthmatic with a chronic productive cough, purulent sputum, or X-ray evidence of lung infiltration has either asthma complicated by an infection, chronic bronchitis, emphysema, or pneumonia, or some combination of these conditions. It is essential to the definition of pure asthma that there be periods of freedom from all symptoms during which airway resistance is normal, as measured most accurately in the whole body plethysmograph.
What pathologic differences are there between the patient who has attacks once a year and the one who has attacks once a month?
An asthmatic who has an attack once a year may be a young adult or a child, and if he came to autopsy, his lungs would probably show nothing abnormal. However, an asthmatic who has an attack once a month would show pathologic changes, primarily in his bronchi and 1 millimeter and larger bronchioles. Mucus plugging of the airways is the most prominent feature.
What about the patient with severe asthma?
The lungs of a patient who dies in status asthmaticus are voluminous and retain air after removal from the body, though there are atelectatic areas. This trapping of air was caused by hyperinflation. not the tissue destruction and loss of elasticity associated with emphysema. Bronchi and bronchioles are occluded by extremely tenacious mucus plugs. Prominent among the multiple findings are eosinophilic infiltration and a greatly thickened epithelial basement membrane.
Is there a difference between the young adult with allergic asthma and the older patient with what is called cardiac asthma?
Cardiac asthma is an unfortunate misnomer and refers to acute pulmonary edema. The primary lesion is cardiac, but the disease manifests itself in the lung. It is sometimes difficult to decide whether acute paroxysmal dyspnea is due to pulmonary edema or a combination of bronchospasm and secretions. Since rhonchi are commonly audible over the entire chest in pulmonary edema, also clinical differentiation can be difficult. Therefore, cardiac asthma defies precise clinical description, physiologic measurement, or morphologic observation. The young adult with allergic asthma may have the disease for many years in mild form without impairment of pulmonary function. During an acute episode, these patients are dyspneic at rest and orthopneic. Loud rales and rhonchi are frequently audible. The rales in the smaller lumen bronchioles and the rhonchi in the larger lumen bronchioles and bronchi. Both, however, are caused by the rustling of mucus during inspiration and expiration. The elderly asthmatic, on the other hand, usually has some associated infection leading to alveolar destruction or cardiac disease leading to similar manifestations.
How does asthma progress?
I should like to introduce the concept of irreversibility at this point. Repeated asthmatic attacks lead to tissue destruction and eventually emphysema. The bronchioles become plugged with inspissated mucus and shed bronchial epithelium. The formation of bronchial plugs is secondary to the loss of ciliary function. The patient is affected by chronic bronchial spasm, and many of his bronchioles are collapsed. The characteristic cough, increased airway pressure, alveolar destruction, and loss of elastic tissue lead to emphysema.
What are the basic mechanisms underlying this development?
The tracheobronchial tree has two primary mechanisms for ridding itself of foreign bodies and mucus. These are coughing and this extremely important ciliary action, which is sometimes forgotten. Cilia are functional only when a blanket of thin mucus lies over them, such that anything present in the airway is carried toward the mouth with the rhythmic beat of ciliary action. When mucus thickens and ciliary action is impaired, whatever mucus and particulate matter are produced remain in the far reaches of the tracheobronchial tree, and the bronchioles become plugged. The material thus blocked in bronchioles and alveoli provides a very good culture medium for bacteria. There is another aspect to the pathogenesis of pulmonary changes. As obstruction increases, the patient becomes more dyspneic, and this is accompanied by increased wheezing and coughing in the attempt to dislodge these plugs. Coughing in this weakening patient also becomes increasingly ineffectual, and a vicious cycle ensues.
Is nothing more known about the causes of bronchial plugging?
It may be due in part to inadequate fluid intake during prolonged attacks, but on the other hand, this inspissation of secretions and formation of mucus plugs may be the primary reason for the initiation of the asthmatic attack. To my knowledge, there is no fundamental information on why this occurs in asthmatics and does not in normal patients.
Are investigations being conducted in this area?
The biochemistry of mucus is as yet incompletely understood, and it may be that asthmatics, and this is highly conjectural, secrete a different type of mucus before an attack, different both chemically and with respect to viscosity. Again, it is conjectural. but someday it may be possible for an asthmatic to test his mucus much in the fashion of a diabetic who tests his urine. And when the expectorate indicates a change, he might expect an asthmatic attack.
What is the therapeutic approach to bronchial plugging?
Humidification through parenteral and inhalation fluid therapy becomes a major goal in treatment. When thick, hard mucus plugs are softened and ciliary activity resumes, the asthmatic attack may come to an end. Paradoxically, when the patient begins to improve, his watery, less viscid secretions begin to fill the tracheobronchial tree, to obstruct more of the airway, and contribute to a continuing elevation in airway resistance. This may be a significant clinical problem in a weak, tired, and possibly toxic individual.
When does cor pulmonale start to be a problem, and how do you recognize this point?
Cor pulmonale is not part of the picture of pure allergic asthma. It occurs only in the advanced stages of irreversible, infectious asthma bronchitis, bronchitic or non-atopic asthma. It is recognized by the presence of pulmonary edema and of a large right ventricle detected by percussion, X-ray, and electrocardiographic changes.
The patient has infectious asthma and bronchitis?
Yes. In other words, the patient no longer has a pure or uncomplicated allergic asthma. He may start out with pure allergic asthma, but he ends up with a superimposed infection.
And this means he now also has bronchitis.
Right. He now has, in addition, a bacterial infection. In fact, the bronchitis sometimes becomes chronic. It is at this point that the condition may become irreversible, with the destruction of alveoli. Ultimately, this patient develops an elevated resistance between attacks.
Is there a ventilation perfusion disturbance in acute asthma?
Several authoritative studies have demonstrated that a ventilation perfusion disturbance does occur during an asthmatic attack. In fact, between attacks in severe asthmatics. In England, Rees did a fascinating study which involved giving adrenaline and aminophylline to asthmatics during an attack. Dyspnea and orthopnea were relieved, but hypoxemia persisted. The interpretation was that abnormal ventilation perfusion ratios were the major factor in producing this hypoxemia. The same pattern has been demonstrated with isoproterenol. A recent extensive study by McFadden and Lyons indicated that hypoxemia and respiratory alkalosis are common in asthmatics. The authors demonstrated an increased dead space and an increased alveolar to arterial gradient, but normal diffusion in their patients. They concluded that 25 to 40% of the lung volume, the areas in the lung with the lowest flow resistance, received 80 to 90% of the inspired air. Thus, a relatively small but controlling number of alveoli are hyperventilated in relation to their perfusion, causing hypoxemia, a large physiologic dead space, and a net ventilation perfusion ratio higher than normal.
Should specific steps be taken in preparing for elective surgery the patient who has a vague history of asthma?
Many patients claiming to be slightly asthmatic probably are not. They have some vague history of dyspnea and wheezing and have been labeled asthmatics. On the other hand, there are true mild asthmatics who have not had an attack in years. They may smoke, they may have some signs of bronchitis, and even wheeze at times, but they are not dyspneic. Preoperatively, both these types of patients should have one simple pulmonary function test, the FEV1, that is the timed vital capacity 1 second. If the FEV1 is less than 1 liter, this patient does have obstruction. especially if the 1 second volume represents less than 70 to 80% of vital capacity. Any asthmatic should have a routine chest X-ray. And since we have access to IPPB machines, there's no reason why he can't have a preoperative trial of isoproterenol with a ventilator to see whether a low FEV1 improves. This would indicate whether his asthma is reversible. Wheezing or dyspnea may be alleviated. If liquefaction of secretion occurs and he is able to bring up secretions, all the better. This procedure will also serve to accustom the patient to postoperative treatment with ventilators.
What about preoperative preparations for the patient with chronically recurring asthma?
This patient should be approached with a certain degree of caution. We've always used postural drainage, and there's no reason why an asthmatic cannot practice deep breathing. This will mobilize secretions, ventilate areas of lung not otherwise ventilated, and also get him accustomed to deep breathing postoperatively. The patient with a recent severe attack should have an assessment of his preoperative venous to arterial shunting, dead space, and blood gases. These data serve two functions. First, if the shunting and hypoxemia on breathing air are severe, improvement should be effected preoperatively. And second, findings serve as a baseline for postoperative blood gas studies.
What preoperative medication and sedation should be given the true asthmatic?
This falls into the realm of personal experience because no controlled study has been done in this area. I certainly want an asthmatic to get a good night's sleep, and I give him 1 milligram per pound of body weight of barbiturate. I think he should have parenteral pentobarbital or secobarbital plus atropine or scopolamine on the morning of surgery. Occasionally, I add diphenhydramine for its antihistaminic properties, and I prefer to schedule surgery in the morning and not in the afternoon to avoid the more likely eruption of an asthmatic attack during a morning of anticipating surgery. The use of narcotics in asthmatics carries the disadvantage of respiratory depression persisting into the recovery period. Tranquilizers as a group have had well over a decade of clinical trial. They all have some disadvantages, such as causing circulatory depression, potentiation of central nervous system depression when other agents are used, and relative unpredictability in duration of effect.
In what situation would atropine be indicated?
Some people consider atropine relatively contraindicated in the asthmatic because it is an anticholinergic and therefore should be expected to cause drying of secretions, further plugging, and perhaps the initiation of a severe attack of asthma. However, there is no evidence to prove this. I believe its vagal blocking activity is of value in general anesthesia. Therefore, I do use atropine. Quaternary atropine derivatives, such as atropine methanitrate, appear not to cause tachycardia or to thicken secretions, effects that have been attributed to the tertiary salts, such as atropine sulfate. When the quaternary derivatives come into greater clinical use, perhaps the one theoretical objection to atropine may be discarded. Smith and Du Bois recently have shown that scopolamine significantly lowers airway resistance. Perhaps it should be used more often in asthmatics. Of course, atropine has also been shown to lower airway resistance.
Is morphine contraindicated?
Morphine and other narcotics in adequate dosage for sedation cause a shift of the carbon dioxide response curve to the right. This means that respiratory depression will occur for a period of 2 to 4 hours. If the anesthesiologist believes that the sedating effect is more important than the possibly persistent respiratory depression, then he should use the narcotic, but in limited dosage. In general, I prefer to avoid the use of narcotics in asthmatics, but there are always exceptional situations.
When is thiopental contraindicated?
Thiopental is a thiobarbiturate, and clinical evidence indicates that they may cause coughing, although infrequently, which may lead to bronchospasm. I myself do not use thiopental as an induction agent in a true asthmatic, and I would certainly avoid the combination of thiopental and cyclopropane, which appears to be particularly detrimental here.
Is another barbiturate better?
An oxybarbiturate such as methohexital is as rapidly acting as the thiobarbiturates used for induction. Slower acting pentobarbital or secabarbital may be used intravenously in the 150 to 250 milligram dose range and may appreciably facilitate induction.
Do you ever use general anesthesia when another technique is available?
For surgery of the lower extremities, perineal and inguinal regions, conduction anesthesia is probably the technique of choice. There are, however, limitations. If the surgeon has to enter the peritoneal cavity, or if the operation continues beyond the 2 to 3 hour time limit of most conduction anesthetics, a general anesthetic will have to be superimposed on the conduction anesthesia in a distressed patient. This can be extremely difficult and dangerous. The patient may vomit, aspirate, and, despite all heroic measures, go into an asthmatic attack that can lead to cardiac arrest and death. Therefore, general anesthesia should not be given if another approach is clearly sufficient. I am sure that a skillful, experienced anesthesiologist working with a surgeon experienced in abdominal surgery could administer spinal anesthesia for intraperitoneal surgery in a severe asthmatic.
Which anesthetic agents are indicated and which contraindicated?
I think that it would be extremely difficult to say that this anesthetic agent or that is absolutely indicated or contraindicated in the asthmatic patient. I believe that the skill and the experience of the man administering the anesthetic, in other words, the art, is far more important than the technique or agent. It does appear, however, that certain general anesthetic agents have in recent years been associated with great success in the management of asthmatics. Several studies indicate that halothane is an extremely valuable agent associated with fewer complications than thiopental nitrous oxide, cyclopropane, or ether. Methoxyfluorane and fluoroxine, also halogenated hydrocarbons, appear to be valuable in the management of the asthmatic, but no study of these newer agents have been conducted yet. Diethyl ether, which for years has been the agent of choice for the management of the asthmatic, has two primary disadvantages: delayed onset of action and the tendency to stimulate secretions. Halothane, on the other hand, does not seem to stimulate secretions in significant amounts and is much more rapid in onset of action. It is also much more acceptable to the patient.
What agents would you not use?
Two, I should say, carry a stigma. They are thiobarbiturates, such as thiopental and cyclopropane. And there is evidence, primarily of a clinical nature, that both are associated with the development of asthmatic attacks during anesthesia.
Each one or both in combination?
Individually and in combination. It is thought that the combination is especially detrimental. In our study, the incidence of complications with cyclopropane alone was 29%. With thiopental and cyclopropane, it was 86%. When ether was added to the thiopental and cyclopropane combination, the incidence of complications fell to 36%. On the other hand, the incidence of complications with halothane alone was 10%. But when halothane was used with other agents, including primarily thiopental, the incidence was 33%.
Should intermittent positive pressure breathing be used during anesthesia for the asthmatic?
Used correctly, positive airway pressure intermittently will increase alveolar ventilation and, within limits, induce a relatively normal arterial carbon dioxide and high arterial oxygen tension. It also increases the physiologic dead space. And it also tends to prevent alveolar collapse and the ensuing complication of venous admixture. Collapsed alveoli are extremely difficult to reinflate. Carbon dioxide retention has been associated with bronchoconstriction, and intermittent positive pressure breathing may preclude this.
Does controlled ventilation have an advantage over assisted ventilation?
Some anesthesiologists prefer to have patients breathing spontaneously at the end of surgery, and this may be easier to do with assisted ventilation. The question may resolve itself if muscle relaxants must be used, since the patient would then be apneic. I prefer to avoid guesswork with respect to alveolar ventilation, and I control ventilation, thereby ensuring that my patient has normal blood gases.
What special problems are presented by curorization?
The use of D-tubocurarine is believed by some to carry the small risk of histamine release and increased airway resistance. There is also the very rare possibility of an acute bronchospastic attack. 2 or 3 cases are published each year. One other possible reason for not using curare is the fact that it must be reversed with agents such as prostigmine, known cholinergics that can stimulate secretions and also bronchoconstriction. I prefer to use either succinylcholine or galamine, either in intermittent doses or a drip. To my knowledge, there have been no publications concerning any difficulty with these 2 relaxants in asthmatic patients, although isolated instances of bronchospasm have been reported in non-asthmatics.
Should positive pressure be used during expiration as well as inspiration?
Positive pressure during expiration has the theoretical advantage of opening up atelectatic alveoli and of preventing airway collapse. This can be useful in a bronchospastic individual, although how useful remains to be determined by physiologic investigation. If the patient is in an attack, expiratory positive pressure may prevent alveolar collapse. If he is not in an attack, I cannot see any value in using this maneuver. It has the disadvantage of causing decreased venous return during expiration. This, in turn, may ultimately result in a drop in blood pressure. If used during expiration, positive pressure should be no more than 2 to 3 centimeters of water. If a pressure of 6 or 8 centimeters of water is used, blood pressure may fall.
How do you manage the patient with a vague asthmatic history during surgery?
An asthmatic attack is always possible. I think every anesthesiologist should have access to a nebulizer that has recently become available. In the past, we have had some difficulty getting isoproterenol nebulized and into the bronchial tree with rapidity, convenience, and safety during the administration of anesthesia. We now have an inexpensive, perfected means of accurately nebulizing isoproterenol during general anesthesia by interposing a cassette between the slip joint of the endotracheal tube and the Y-piece and depressing the valve of a pressurized cartridge. This nebulizer can also be used conveniently in association with a tracheostomy, mask, or mouthpiece.
How do you manage the emergency surgical patient who presents with an acute asthmatic attack?
First, this patient should have his vital signs recorded for use as a baseline. He should then receive at least a 5-minute trial of IPPB with nebulized isoproterenol. If conditions permit, and they may not, his FEV1 should be taken before and after IPPB with isoproterenol with a simple instrument such as the McKesson Vitalor. If the patient improves, his asthma is reversible. These patients should receive fluids because they are usually dehydrated. Probably one of the reasons for the development of an asthmatic attack is relative dehydration. They should have a chest x-ray taken as a routine. Even if it is negative, a slight elevation in temperature usually means that they have bronchitis or pneumonia, which in fact may have triggered the attack. This is especially common in the older patient with emphysema who smokes. Antibiotics should be administered. If this patient is clearly allergic, he should be premedicated with diphenhydramine, which acts as both a sedative and antihistamine. Depending on how severe his asthmatic attack is, he should be given steroids preoperatively, the usefulness of which has been demonstrated. Recommended dosage is prednisolone 60 to 80 milligrams intravenously, or hydrocortisone 200 to 500 milligrams intravenously in an intravenous drip. An old-fashioned but useful approach is intramuscular epinephrine. It may also be given intravenously 1 milligram in 250 to 550 milliliters in a drip. However, if this is used, a halogenated hydrocarbon can be administered as the anesthetic agent only with the utmost caution. An infusion of 100 to 200 milliequivalents of sodium bicarbonate in 500 cc of 5% glucose in water at a rate of 2 to 5 milliliters per minute may be in order in an advanced asthmatic who is in a prolonged attack and is extremely tired and who needs emergency surgery. Aminophylline, 500 milligrams in 500 milliliters, may be added to the drip.
How do you manage a patient who develops bronchial constriction?
This is a very difficult problem. First, it is important to determine whether it is actually bronchoconstriction. Frequently, light anesthesia is the primary reason. The patient has an extremely sensitive tracheobronchial tree, and he is bucking, straining, or coughing on a foreign body in his trachea. He then develops a wheeze, and indeed may go on to develop bronchospasm. Succinylcholine or galamine should be administered in adequate dosage to relax skeletal muscle. If the patient can then be ventilated, the cause of the ventilatory difficulty was not bronchoconstriction, but simply light anesthesia. If, after an adequate dose of muscle relaxant, ventilation is still very difficult, it is safe to assume that a bronchospastic attack has occurred. I would then recommend that deeper anesthesia be utilized if the cardiovascular system will permit. Wrapping the patient's legs with elastic bandages and elevating them may be of prophylactic value. It is also important to administer a high concentration of oxygen. I think intermittent positive pressure breathing is important here for the removal of carbon dioxide. Both ventilation factors demand a good airway and therefore the use of an endotracheal tube. Evidence exists on both clinical and experimental grounds that insertion of an endotracheal tube may initiate wheezing and may be associated with increased pulmonary resistance. But the ability to maintain communication with the main bronchi outweighs any disadvantage associated with the insertion of an endotracheal tube.
At what rate should the ventilator be set?
First, I prefer manual IPPB here. I think it is important to auscultate the chest and adjust the duration of the expiratory pause so that the expiratory wheeze ends before the next inspiration starts. This is a very simple but useful maneuver. If a ventilator is used, the tidal volume rate relationship can be determined only by blood gas determinations. I think it is also very important to use a closed or semi-closed system and not a non-rebreathing system, because adequate humidification of the inhaled gas is essential here. It is also important to ask the surgeon to stop if he has initiated peritoneal or hilar reflexes, which, for example, may be stimulating branches of the vagus nerve. The patient may be given atropine in this instance. Another procedure that should be used is the administration of nebulized isoproterenol. There is some doubt about its efficacy when administered intravenously. If the patient is not receiving halothane, he should be switched to it. A second choice would be methoxyfluorane, and a third, diethyl ether. One study of anesthesia in asthmatics severely criticizes ether. At least 2 clinical studies support the superiority of halothane over ether. One physiologic investigation indicates that halothane may have beta-adrenergic stimulating properties and that it lowers pulmonary resistance. Another indicates that it has a minimal effect on pulmonary resistance.
Is pre- or post-operative bronchoscopy indicated?
Only to remove a foreign body. I should recommend that all efforts be made to liquefy bronchial plugs or viscous mucus through nebulization, preferably heated or ultrasonic, rather than use a bronchoscope to remove plugs. If aspiration of a main bronchus is deemed necessary in an asthmatic attack, skillful nasotracheal intubation and the threading of a suction catheter into the involved bronchus would be as efficient as bronchoscopy. I fear bronchoscopy not because it involves possible trauma, but because bronchospasm and hypoxemia occasionally accompany this maneuver in the asthmatic.
How do you aid the therapy of the medical patient with status asthmaticus? Is rectal ether of use here?
There is no role for rectal ether, in my opinion. Anesthesiologists in recent years have taken an active and useful part in treating status asthmaticus. This probably came about because of our knowledge and skill in treating respiratory obstruction and because of our familiarity with the uses and administration of oxygen and other gases. IPPB has been useful in the treatment of moribund asthmatics with or without general anesthesia. Status asthmaticus has been defined as an acute attack of bronchial obstruction, severe from the start and increasing in severity, unrelieved by the usual treatment such as epinephrine, aminophylline, isoproterenol, and steroids. This patient is a prime candidate for IPPB by mask or mouthpiece with nebulized bronchodilators and good humidification.
What sequence is employed?
Assisted ventilation, started with bag and mask and guided by auscultation, should be used first. Then the ventilator should be used. If no improvement occurs, insertion of an endotracheal tube is justified. The patient should be taken to a quiet area, preferably in a respiratory care center, and placed on a volume-guaranteed ventilator with adequate humidification and controlled, not assisted, ventilation. Succinylcholine should be injected intravenously to facilitate intubation. Narcotics may be used in small doses for sedation and to depress the cough reflex during treatment. We also use succinylcholine intermittently to keep the patient from bucking or coughing while he accustoms himself to the endotracheal tube. Blood gases should be measured before and after treatment. The concentration of inhaled oxygen should be charted. I prefer a concentration of oxygen that keeps the hemoglobin oxygen saturation just above 95%. This corresponds to approximately 80 millimeters of mercury arterial pressure with a pH of 7.4. Therefore, 24 to 28% oxygen is indicated in most instances. This must be guided by measurement of arterial oxygen tension. Because ventilation perfusion abnormalities occur in asthma, these figures are approximate.
Do you use mucolytic agents?
Agents other than isoproterenol may be used. N-acetylcysteine is a currently popular mucolytic agent that carries the stigma of possibly creating bronchospasm when used in a 20% concentration. Therefore, I initially use a 10% concentration and add dilute isoproterenol to avoid possible bronchospasm. I would not expect much benefit before 12 to 24 hours of treatment, and I do not recommend its use except when secretions cannot be liquefied after a reasonable amount of treatment with IPPB and humidification with water. I do not recommend the use of detergents. These agents have never demonstrated any advantage over water.
What is the postoperative care for the asthma patient who did not have bronchoconstriction?
Anticipate an attack, provide adequate analgesia, but avoid the use of heavy doses of narcotics.
What about the patient who did have bronchoconstriction?
This patient must be watched with extreme care. He is a likely candidate for another asthmatic attack. His parenteral intake of fluid should be high, and he should be inhaling moist air in a fog or croup tent. Intermittent use of IPPB with isoproterenol every 4 hours may be useful. Chest physiotherapy, suctioning, adequate positioning, coughing, and deep breathing exercises are also of value in the asthmatic patient who did develop bronchospasm during surgery.
Thank you very much, Dr. Gold. Anesthesia Rounds is presented to clinicians in the field of anesthesiology by Airst Laboratories. Anesthesia Rounds, a series of discussions of clinical problems facing the anesthesiologist. Anesthesia Rounds is presented as a service to clinicians in the field of anesthesiology by Airst Laboratories. In this interview, Dr. David Allen, Associate Professor of Anesthesia, Northwestern University School of Medicine, Evanston, Illinois, and head of the Division of Anesthesiology, Children's Memorial Hospital, Chicago, discusses prolonged ventilatory care in children. Among the questions that Dr. Allen will consider are, when respiratory distress in children indicates a need for prolonged mechanical ventilation, the most common clinical settings in which respiratory insufficiency may occur, criteria for selecting a ventilator, procedures for placing patients on and weaning them from ventilators, and the maintenance of patients during prolonged ventilatory care. Dr. Allen, what is respiratory insufficiency?
Respiratory insufficiency implies hypoventilation or hypoxia, or a combination of these entities. It is when hypoventilation is suspected that we consider the use of mechanical ventilation, assisted or controlled.
When you speak of hypoventilation, you refer to alveolar hypoventilation.
Yes,
As determined by what measurements?
clinical estimates of depressed ventilation can be made by judging the depth of respiration, listening to the tidal exchange by stethoscope, or by measuring the excursion of the chest with your hands. But the sine qua non in determining alveolar ventilatory adequacy is the measurement of carbon dioxide pressure in the arterial blood.
What are the indications for mechanical ventilation?
In the vast majority of cases, hypoventilation to a sufficient degree is the indication for mechanical ventilation. But in a few instances, an increased work of breathing and/or an increased metabolic demand indicates the need for mechanical ventilation before fatigue causes a rise of the PCO2. This is frequently true in the infant. In infants and small children, there are different values in every age group for each respiratory factor. This and the low values for tidal volume make it difficult to assess adequacy of respiration and, when indicated, to use mechanical ventilators properly.
In what way are the patterns that indicate the need for mechanical ventilation in children distinct from those seen in adults?
The infant has a high metabolic rate. He breathes almost entirely with his diaphragm, but he has a large abdomen that tends to restrict this diaphragm, and he has a relatively small chest cage. The combination of high metabolic rate, relatively small chest cage and contents, and poor ventilatory mechanics results in a small respiratory reserve. Much less time is available for reacting to impaired respiration in the infant than in the adult. Another thing that is obvious but seldom appreciated is that the smaller the infant, the smaller the airway. When you consider that the 3-kilogram neonate has a diameter at the cricoid of 4 millimeters, you realize that any obstruction in this airway is obviously critical.
What other factors have to be considered?
The various components of the respiratory cycle have to be related to time. In neonates, there is so little time for respiration to occur. For instance, his tidal volume is, say, 16 ml, and 12 ml of that would probably be true gas exchange, and 4 ml dead space. Now, if an infant is breathing 37 to 40 times per minute, that means there is only 1.5 seconds for a complete respiratory cycle, which results in the inspiratory phase being only half 1 second.
What does this mean with respect to artificial ventilation?
Time factors are quite critical when mechanical ventilation of an infant is considered. A good illustration of the difficulties is provided by the so-called educated hand. There are those who say they can assist ventilation in an infant with their hands. They must have lightning reflexes to be able to assist an infant who is breathing 40 per minute because, after sensing the beginning of inspiration, transmitting this knowledge centrally and back to the hand, they must then contract the hand down on the bag, all in nothing point 5 seconds. I'm sure that by the time this has occurred, the infant is on to expiration, while the anesthesiologist is still on inspiration. The same basic principles apply to machine-assisted ventilation. There are some machines, such as the Birdmark A, with J-circle and the R, that have a very fast response time.
What ventilatory patterns?
To begin with, there is nothing physiological about putting pressure on an airway. Similarly, to achieve our purpose, We are not obliged to mimic the normal respiratory cycle in other ways. The goal is to provide the maximum time for gas exchange to occur. Therefore, we are not going to breathe at 40 minutes. We are going to ventilate at as slow a rate as possible, and the slower it is, the greater is the reduction of the dead space of minute ventilation of the patient.
Doesn't this reduced rate provoke greater fighting against the ventilator?
No. One thing I should emphasize is that if there is adequate alveolar oxygenation after the lowering of the PCO2, the patient will not fight the respirator.
How is inadequate alveolar ventilation determined? Is fighting the machine determined?
The patient will not be in phase with the machine, and, of course, the measurement of PO2 will be indicated. If the patient begins to fight when you know the PCO2 is well within acceptable limits, then he is not being adequately oxygenated. This can be due, for instance, to a mucus plug, or the respirators not being set for sufficient ventilation and oxygenation. I should emphasize that any patient on a respirator has some pulmonary shunting. He needs more than ambient oxygen, perhaps 25 or 10% oxygen.
What are the indications for mechanical ventilation of an infant?
Again, I re-emphasize that hypoventilation to a sufficient degree is the most common indication. Now, why do I say to a degree? One thing we should remember is that an assessment by the clinical blood analytical is done in relation to time. For instance, a PCO2 of 55 millimeters of mercury in an infant is not by itself an indication for mechanical ventilation. If that 55 millimeters of mercury occurred 20 minutes after finding of 35 millimeters of mercury, then it would be an indication, because obviously there is decreased ventilation. That's why I say to a degree, and that degree must be measured in relation to time.
There must be a series of measurements?
Yes.
What are the most common clinical situations in which this would occur? What are the most
In children, respiratory insufficiency is most common, of course, in the post-operative period. And there is at least one factor here that is unique to children. Remembering that the knee is a completely diaphragmatic breather. If a phrenic nerve should be injured during thoracotomy, in the correction, say a cardiac anomaly, you must use mechanical ventilation until that nerve regenerates. We have successfully maintained such newborns on ventilators for 3 and 4 months. A situation comparable to one occurring in the adult is the transplacental transmission of whatever it is that causes the muscular symptoms of myasthenia gravis. Here, it's a simple matter of waiting until this clears up by itself. But during the waiting period, when there's almost total paralysis, one has to ventilate these infants. This is easy because the compliance is so great in the myasthenic. Patients with mechanical entities such as diaphragmatic hernias may have to be maintained on a mechanical ventilator.
What other clinical situations might be cited?
The most common medical entities in children are the ingestion of poison, for example lead, the severe bronchopneumonias, and spasmus asthmaticus. None of the others is what one might call frequently occurring. The most common surgical conditions are associated with the correction of congenital cardiac anomalies. One of the most common medical entities leading to mechanical ventilation in recent years has been idiopathic respiratory distress syndrome, RDS, of the newborn. Incidentally, negative pressure ventilators find their most frequent application in the treatment of RDS, although I don't use them.
Further elucidate the criteria for using mechanical ventilation.
the criteria for using mechanical ventilation?
Bearing in mind what's distinctive about an infant's breathing, the history and the probable evolution of the disease. For instance, after a mustard procedure for correcting transposition of the great vessels, the child is routinely placed on the ventilator because we have learned from experience that there is sufficient mismatching of pulmonary blood flow and alveolar air to cause eventually significant respiration suffering.
Aside from analyzing blood gases, do you use specific analytic methods in assessing respiratory status?
If possible, blood gas analysis should be done because it's the most accurate method of continuously monitoring the respiration with respect to the need for mechanical ventilation or the proper setting of the ventilator controls. Pulmonary function tests are of some value in children. Take, for example, the Guillain-Barré syndrome, relatively common in children. It is a relatively common associated with an increasing ascending paralysis when it reaches a certain level affects the phrenic nerve. If proper mechanical ventilation is provided, the child recovers. When evaluating ventilatory function here, we measure the tidal volume and the vital capacity and relate the tidal volume with respect to time. Should this ratio be markedly reduced, mechanical ventilation is indicated. It is not absolutely essential to have blood gas analysis, but it sure helps.
What procedures do you use to place a patient on a ventilator? What procedures do you use to place a patient on a ventilator?
Considering mechanical ventilation is hypoventilation. The first thing to do is reduce the dead space by either inserting an nasotracheal tube or by doing a tracheostomy. This step may be sufficient to remove the need for mechanical ventilation.
What procedure is followed if it is decided that the reduction of dead space is not sufficient to restore an acceptable alveolar ventilation?
To restore an acceptable alveolar ventilation. We will ventilate the infant through a nasotracheal or a tracheostomy tube. If you know that mechanical ventilation is going to continue for more than 48 hours, then you might as well do a tracheostomy at the beginning under controlled circumstances. If you estimate that mechanical ventilation will continue for less than 48 hours, then we would suggest using a nasotracheal tube, usually one of Jackson Reese. Now, there is much difference of opinion on this subject. There's an excellent series of very long, up to 3 months, through Jackson Reese. But our experience was rather disturbing. In the first 14 long-term mechanical ventilations we did with nasotracheal intubation, we had 2 cases of subglottic stenosis.
How do you select a ventilator once the question of airway is settled?
That creates more emotion than the attributes of various types of ventilators. When considered the discussion on selection is limited by the requirements and for supplying a 12 to 16 ml tidal volume, which would give you a minute volume of 40 ml, about the normal for a 3 kilogram needle. But more important, the ventilator must provide an average inspiratory flow of only 2 liters per minute. That would be about 20 liters per minute. That would be about 20 liters per minute. Are totally suited for use on infants.
How wide a field do you have to select from?
First, one must decide between negative pressure and positive pressure ventilation. I do not think negative pressure ventilators are effective.
What is your objection to negative pressure?
When we finally did begin to do some blood gas analysis in the days of the anterior poliomyelitis epidemic, we were amazed at how inadequate we were in fostering gas exchange. It was thought that intubation would be avoided, but this is not so with 50%. But this is not so with 50% of neonates in a box. It is also difficult to nurse a patient in a box. Respiratory physical therapy is practically impossible under these circumstances.
What explains the need for the very slow
What is desired is a flow curve with a very slow beginning, and then very rapid rise. Slow to begin with, to get through any obstruction.
Slow to begin with, to get through
fluids obey the same physical laws.
Gases and fluids obey the same physical laws. If you wanted to get water through a small orifice, you would pour it slowly. Pour it too fast and it won't go. So, to get a gas through a small orifice, you start off slowly. The flexible orifice usually opens up because of the equalization.
You must now put the rest of the gas into the alveoli in a limited time. So
into the alveoli in a limited time. So you must do it very rapidly.
What other criteria are used for selecting a ventilator?
Are classified
The
the
positive
volume
pressure
limited or pressure
ventilators are
limited.
classified
Then the
volume limited or pressure
ventilators are
limited.
again
And then the volume
into
limited
increasing
ventilators
force
are again divided into increasing force generators such as the Angstrom or constant force generators such as the Born.
limited ventilators,
Now, when we talk about pressure limited ventilators, we are interested in whether the inspiratory flow can be varied as it can on the bird ventilators
On
and
what
Bennett
basis would one make a
PR2, for
decision?
example.
On what pressure limited, one make a volume limited. First, between pressure limited and volume limited devices,
we
and
want
then
a means
within
of
these
knowing
classes.
quickly
We want a means of knowing quickly and precisely what the oxygen concentration is in the gases being delivered to the infant.
The oxygen is
In
entrained.
pressure-limited machines, the
entrainment
oxygen is
depends on the
entrained.
inspiratory flow
This
because
entrainment
the
depends on the
ventilator is being
inspiratory
driven by
flow
compressed
because
air.
the ventilator is
minute
being
volume
driven by
of
compressed
oxygen
air.
has to be adjusted
The
to
minute
inspiratory
volume of
setting.
oxygen has to be
With
adjusted
an
to the
Emerson,
inspiratory
one
setting.
would have to
With
analyze
an
the gases
Emerson,
in the circuit
one would
and do
have to
empiric
analyze the
adjustments
gases
of
in the
oxygen
circuit
flow.
and do
Whereas
empiric
with the
adjustments of
Angstrom,
oxygen flow.
one can dial
Whereas
in the
with the
desired
Angstrom,
concentration
one can
instantly.
dial in the
You have
desired concentration instantly.
You have control.
You have control.
Now remember
You
that
have
an
control.
infant is much
Now
more
remember
susceptible to
that an
infection
infant
than an
is
adult.
much more susceptible to infection
Sterility
than an
control
adult.
of any
Therefore,
inhalation therapy
sterility
apparatus
control
used for the
of any
neonate is
inhalation
critical,
therapy apparatus
especially
used for the
when there's
neonate is
water
critical,
associated with the use of the
especially
instrument.
when there's water
The next
associated with the
requirement
use of the
is that
instrument.
the instrument
The next
obviously
requirement
must have a
is
sufficient
that the
average
instrument
inspiratory
obviously
flow
must have a
and one low
sufficient
enough
average
to accommodate the
inspiratory flow and one low enough to
Then
accommodate
we
the
should have
instrument.
a means of readily dialing in
Then we
the
should have
correct
a
minute
means
or
of readily
tidal volume.
dialing in the
This
correct
also
minute
can be
or
done
tidal
extremely
volume.
simply on the
This
instrument.
also can be done
addition,
extremely
It
simply
is
on
the
the
only
instrument.
machine
In
that I am
addition,
familiar
it
with
is the
that
only
automatically
machine that I am familiar with
accommodates to
that
changes in airway
automatically
resistance
accommodates to
pulmonary
changes
compliance,
in airway
thereby
resistance and
maintaining
pulmonary
a constant
compliance,
minute volume
thereby
in the absence
maintaining
of
a
leak.
constant minute volume
Now,
in the absence of leak.
pressure-limited devices have the
Now,
advantage of
pressure-limited
accommodating to some
devices
extent
have the
to a
advantage
leak
of
in the circuit.
accommodating to some extent to a
This
leak in the
accommodation
circuit.
cannot take
Obviously,
place in a
this
volume-limited
accommodation
respirator.
cannot take
The
place
patient
in
is
a
going to be
volume-limited
hyperventilated.
respirator. The patient is going to be
These ventilators
hyperventilated.
should be capable of
Also,
generating
these
relatively
ventilators
high
should be
pressure.
capable of generating
Because of the small
relatively
airway,
high pressures.
The normal airway
Because of
pressure
the small
needed in a
airway,
neonate is
the
about
normal
30
airway
centimeters
pressure
of
needed
water.
in a neonate is
If
about
any
30
obstruction
centimeters
is
of
present,
water. If
It is
any
not uncommon
obstruction
to
is
need
present,
pressures of 50 to
it's
60
not uncommon to need
centimeters of water.
pressures of 50
Many
to 60
ventilators
centimeters of
cannot
water.
generate such high
Many
pressures.
ventilators cannot
Which
generate
do.
such high
The
pressures.
Angstrom, Emerson,
Which
Bird,
do.
Burns,
The
and Bennett.
Angstrom,
The better
Emerson,
ones we've been
Bird,
discussing.
Burns, and Bennett. The
But
better
it is
ones
usually
we've
much
been
easier
discussing.
to train someone to
But it's
use an
usually
Angstrom
much
than
easier to
any
train
other
someone
ventilator.
to use an Angstrom
Dial in
than
your
any
oxygen,
other ventilator.
minute volume, and
You
machine
can
dead
dial in
space.
your oxygen,
And it is
minute
so
volume,
simple
and
to
machine
do.
dead space.
Whereas
And it is so
with
simple
other
to do.
machines, you may have to
Whereas,
worry
with
about
other
a
machines,
sensitivity control,
you may have to worry
an
about a
inspiratory
sensitivity control, an inspiratory control, an expiratory control, a pressure control, and each one is related to the other. So if you change one, you've got to change them all. And everything empirical, while an Angstrom is quantitative.
And there's no comparable machine?
Well, the Emerson is similar in design, but is not sufficiently
has
accurate.
changes of
You
100
see,
ml
the standard Emerson has changes of 100 ml per ton of the volume
of a
dial,
few
while
ml
we are
at a
concerned
time.
with variations of a few
Then, of
ml
course,
at a time.
Any acceptable
Then,
ventilator
of
should
course,
have adequate
any
means for
acceptable
introducing
ventilator
humidity to
should
the
have
airway.
adequate means for
And
introducing
since
humidity to the
ventilators are
airway.
usually used on
And since
abnormal
ventilators
airways
are usually used on abnormal airways, that frequently are obstructed to some degree, also means for introducing mist to mobilize secretions below the carina.
Please differentiate between mist therapy and humidification.
Humidity is the water vapor, that is, the molecular water carried by a gas. Mist and aerosols, generated by nebulization, are composed of particles of water or medication.
What is the clinical significance of this distinction?
One should remember, when talking about the difference between humidification and mist therapy, that there is always 100% humidification beneath the carina. Therefore, Introducing additional humidity here will have little influence.
in treating
It
humidity
can only be
deficit
of
of the
value
larynx
in
and
treating
trachea.
humidity deficit
other
of the
hand,
larynx and
mists
trachea.
and aerosols
On the other
can be
hand,
deposited
mists and
depending on
aerosols
particle
can be
size
deposited
anywhere in the
depending on particle size anywhere in the tracheobronchial tree. The newly developed ultrasonic nebulizers produce, independently of gas flow, a stable mist,
can also
permit
be
control of
used as a
particle size,
humidifier.
and can also be
There is
used
also
as a
significant
humidifier.
difference between
There is also
humidification
significant
and
difference
nebulization in
between
relation to the movement of
humidification and nebulization in relation to the movement of
humidifier
bacteria.
promotes
A
vaporization.
humidifier promotes vaporization. It does not move particles. Should it become contaminated with bacteria, the bacteria will not be moved from humidifier to patient because bacteria are particles. A nebulizer does move particles. If it becomes contaminated, then infection will be transmitted.
Is there real danger in rapidly reducing arterial PCO2?
May go into shock.
The patient may go into shock. This is, by the way, much more likely to occur in a geriatric patient than in the infant. One of the mechanisms here involves the production of adrenaline in the presence of a high PCO2. Because the pH is low under these circumstances, the adrenaline would not be utilized until the pH is suddenly brought to normal by rapidly reducing the PCO2. Another potential mechanism of shock is the cerebral vasoconstriction associated with a rapid drop in
For using
PCO2.
neuromuscular blockade. What are the indications for using neuromuscular blockade or respiratory depressant?
I should like to emphasize that the vast majority of infants and children on mechanical respirators need neither muscle relaxants nor respiratory depressants. If they receive adequate oxygen, they will go with the respirator very well indeed.
When do you use a neuromuscular blockade or a respiratory depressant?
The exception to the rule of using nothing occurs when there is a large central shunt, either cardiac or pulmonary. The more common, of course, is the cardiac shunt in the so-called blue babies. In these babies, the respiratory stimulus is not CO2, but hypoxemia. There is no way to oxygenate these children fully or to change the basis of their respiratory drive. Here is where you would use either a respiratory depression, morphine being the drug of choice, or neuromuscular blockade. We prefer morphine because it lowers the metabolic rate. When we are concerned about the depressant effect of morphine on the heart, we use a muscle relaxant.
What relaxant would you use?
I would use galamine if there's no tachycardia, although many prefer curare. The former produces tachycardia and, remember, in managing the infant, the one thing to be avoided is bradycardia. The main monitoring index in the infant is the pulse rate. The first clinical sign of hypoxia in the infant is bradycardia, a slow pulse. If tachycardia is present, then curare is the drug of choice. It is introduced on a continuous basis by using an electrically driven syringe.
What indices do you use to determine when to wean the patient from the ventilator?
The primary point is whether the disease appears to have run its course. If, in bronchopneumonia, we see that the disease is receding and that the blood gases stay normal day after day when the oxygen has been lowered to 30%, then we will consider weaning.
Please describe the weaning procedure.
It is often a long procedure, but it is characterized by its variability. We try to establish normal ventilation on the ventilator, avoiding, if we can, hyperventilation as well as hypoventilation, so that in 30 seconds of coming off the ventilator, patients should be able to breathe on their own. If they breathe on their own, we'll leave them off for up to an hour to see how well they do, then place them back on the ventilator. The time off the ventilator is then gradually increased. For the first 2 or 3 days, they go back on the ventilator at night for rest and to avoid a work of breathing crisis during the night. We use blood gas analysis as our major index and do spirometry with the older children. There are no adequate spirometers for use with infants. The flow rates are too low.
How do you prevent aspiration during prolonged ventilatory care? Is cupping used?
We try to fit tubes. We avoid the use of cuffs on small children because we don't want to reduce by any amount an already small airway. If a cuff tube were used, a smaller size tube would be necessary. With respect to preventing aspiration, when using a nasotracheal tube, which we would not do for more than 2 days, we use IV feeding. With tracheostomy, you can use gavage or bottle feed them. This is an area of management.
Bottle
I feed the patients
Many will
normally. Feed them. Many
have been
will
very
disagree, but our
How do you
results
prevent the
very
slipping
good.
of the tracheostomy tube? How do you prevent the slipping of the tracheostomy tube? And how do you support the tubing from the ventilator?
It should be emphasized that lateral X-rays should always be taken when placing a tracheostomy tube or, for that matter, a nasotracheal tube to determine its location. We use only single-lumen plastic tubes in mechanical ventilation. The tubes are cut down to the proper size so that they can't slip into a bronchus. They also have wings on them. Methods for supporting the tubing from the ventilator are relatively unsatisfactory. With a Jackson-Reese tube, we use thick-wall rubber tubing fixed to the patient's head with a turban and tape. With a tracheostomy tube, we connect to it either directly by using a short piece of endotracheal tubing or indirectly by using a bird connector and a very thick-wall rubber tubing that connects to the ventilator tubes.
How do you manage secretions? Do you use mucolytic agents?
We have not used mucolytic agents since the advent of the ultrasonic nebulizer. They were used primarily because the mechanical nebulizers were inadequate. About the only drugs we use now in respiratory care are the bronchodilators, isoproterenol and racemic epinephrine. The management of secretions depends on adequate humidification so that the lungs' scavenging mechanism can function. Below a relative humidity of 70%, the major mechanism, ciliary activity, ceases to function. The cough mechanism is seldom useful under the conditions of prolonged ventilator care. Therefore, one should use mist therapy for mobilizing secretions in the lower airway. This is usually done with the use of an ultrasonic nebulizer. The outward movement of these secretions is aided by postural drainage, even with the patient on the ventilator, and respiratory physical therapy, which consists of either percussion or vibration. Then, of course, one can provide direct suction through the tracheostomy or nasotracheal tube, the former being much easier to use. One indication for leaving a tracheostomy tube in place is the need for adequate suctioning.
Is fluid balance affected by humidification?
Yes, there will be no insensible loss of water from the respiratory tree when a patient is on a respirator. More importantly, if an ultrasonic nebulizer is in the line, you may add fluid, a critical factor in the very small neonate, especially its premature. When compiling maintenance requirements, it is wise to reduce them by about 20% to allow for the absence of insensible loss. We prevent overhydration of the newborn by regular weighing, subtracting any undue gain from the following day's maintenance fluid requirements. Perhaps special mention should be made of the ultrasonic nebulizer in the weaning process. It is very important to keep the airway well moistened when the patient is removed from the ventilator for periods of time during the weaning process. This is accomplished by using an ultrasonic nebulizer, usually in association with a tracheostomy collar. It is also possible to scavenge the mist from the nebulizing cup with varying concentrations of oxygen, so that it is relatively easy to attain any level of oxygen at the airway that one deems necessary. This should be verified by using an oxygen analyzer.
Is prolonged hyperventilation of value in cerebral edema?
It can be of value during the first 4 days of cerebral edema. If there is no improvement in this time, there will not be a beneficial result. Hyperventilation under these circumstances is used in conjunction with dexamethasone and mannitol, and if the cerebral edema is the result of cardiac arrest, probably sodium bicarbonate and SAM to control metabolic acidosis.
In the postoperative patient with metabolic acidosis, respiratory alkalosis, and mild tachypnea, what do you do when the treatment of acidosis with bicarbonate does not decrease the respiratory alkalosis or the respiratory rate?
One would not expect, under these circumstances, to elicit an immediate response. Remember that it is difficult because of the blood-brain barrier to influence the level of hydrogen ion in the cerebrospinal fluid rapidly. The respiratory rate will slow eventually. The compensatory respiratory alkaloses will respond to the lessening of the metabolic acidosis.
When is oxygen toxicity of concern to you?
Oxygen toxicity is of concern whenever oxygen is in use. It is a very valuable agent, but oxygen should never be used in greater concentration than needed to do an effective job. Modern thinking on oxygen toxicity suggests a danger of airway and lung changes after 24 hours of high concentration. Oxygen should never be withheld when hypoxia is present. There is a very interesting saying, the brain gets softer far quicker than the lungs get harder. What one should do as soon as possible is reduce the oxygen concentration not to ambient, but to 25 or 30% concentration. One can do this readily by monitoring the arterial PO2.
Dr. Allen, would you please indicate the differences that should be borne in mind when evaluating infant and adult PaO2?
The norms with respect to arterial PO2 are quite different in the adult and the neonate. First has been described as a race against anoxia, and the normal arterial PO2 of the neonate is 15 millimeters of mercury. Therefore, it is ridiculous to attempt to attain a higher PO2. The PaO2 gradually increases and is usually within so-called adult levels within 2 months. It should be remembered that the resistance of the pulmonary circulation is 600 dyne at birth, very high indeed. And of course, you also have the normal cardiac shunts for about the first 2 months of life, and you must add to this the effect of the pulmonary shunting associated with artificial ventilation.
How do you manage the patient in shock with a low PVO2 and PaO2, one who reacts poorly to increases in mean intrathoracic pressure?
Obviously, there is an inadequate amount of circulating blood volume. Therefore, one must determine whether this is due primarily to cardiac failure or hypovolemia. With cardiac failure, we digitalize the patient. If findings were due to lack of volume, then we would transfuse with blood. A poor response to increases in mean intrathoracic pressure is probably due to a too rapid ventilator rate. In this type of patient, one should set the slowest rate possible so that there is adequate time for cardiac filling during the expiratory phase.
Please outline the medications and orders you would suggest for a patient on his 3rd to 10th ventilator day.
By the 3rd day, the oxygen level should have been reduced to 25 or 30%, unless the disease process is extremely severe. This should give a normal PO2 of over 90. The ventilator rate should also be kept to a minimum, a maximum of 26 per minute in the neonate. The dry gases, air and oxygen, must be humidified, and if obstructive lung disease is present, the use of a nebulizer should be ordered. If secretions are insufficiently mobilized, then respiratory physical therapy and suctioning, which must be conducted under absolutely sterile conditions, should be ordered. Everything in contact with the patient on a ventilator should be at least as sterile as it would be during an operating room procedure. Because water is an irritant, 1/3 normal saline should be used if the tracheobronchial tree is sensitive. Intermittent bronchospasm is treated with isoproterenol, usually 0.5 ml of 1 in 200 isoproterenol in 5 ml of saline as a diluent.
What about monitoring respiratory factors?
This is simple with a non-dispensable system such as is used in a volume-constant respirator. The rate and inspiratory volume are preset, and the airway pressure and expired volumes can be read directly. These should be continually monitored. A rapid increase in pressure indicates obstruction and, probably, the need for suctioning. Fluids, as I've said, should be reduced by at least 20% from calculated maintenance requirements. Electrolytes should be ordered on the basis of laboratory findings. As I mentioned before, we feed the patients who have been tracheostomized, and the vast majority will have been in a normal manner per orally. Bone marrow depression appears to be associated with long-term ventilation, and this may occur as early as the 10th day. It is reflected in a lowering of hematocrit and hemoglobin. It is frequently necessary to give a blood transfusion to a patient who has had long-term ventilatory assistance.
Would you comment on the psychologic aspects of prolonged ventilatory care in children?
The child on long-term ventilator care needs as much of his parents' attention as possible. The less well he is doing, the more he needs physical contact and love. It has been proven beyond any shadow of doubt that this is highly significant in the management of these children.
Thank you, Dr. Allen, for a most useful discussion. Anesthesia Rounds is presented as a service to clinicians in the field of anesthesiology by AIR Laboratories.